today uh, we will be dealing with the stroke. Now we've had the basis of anatomy, and I've heard some of you guys had exam today, and I hope those people had a good exam. And finally, we have, after a long series of lectures, I finally come down to stroke interventions. But again, I will have to take a bit of imaging because ischemic stroke, the the intervention is extremely linked to the imaging, because you have to take very fast decisions. You should be clear what you're looking at. You should be understanding that अगर किसी ने बाहर, if somebody has got a CT done, what all you can look at it, what's the next imaging, should you get an MR done, should you get a CT angio done, what's the role of perfusion, what kind of perfusion you do, what you look in that, uh, and a lot of things perhaps maybe you can only learn when you see more and more of cases. I have 4 or 5 cases as well in this lecture, just to show in the end. But the primary idea in stroke interventions is to know the initial imaging, the signs. I'm not sure, maybe in some of your neuroimaging lectures also acute stroke might have been covered, but we'll try to uh, just keep that part intact here, where which is extremely important for decision making in stroke. So of course, the basic definition has to be there. It's always asked, sudden onset. So sudden onset history is very important. So I'm also considering the fact that few of you might be interested in becoming a neuro-interventionist in the future, or intervention radiologist who can do stroke at least, if not maybe the high-end uh, neuro-intervention work. So the basic idea when you pick this up is that is the onset of the deficit. There has to be a neurological deficit, ki weakness aa gaya, ya is not able to speak, speech is an issue, vision is a problem, anything, any focal deficit which can be due to vascular injury or origin. So CNS injury due to vascular region leading to a focal neurological deficit. And it could be because of an ischemic stroke or could be because of hemorrhagic stroke. It's 80-20 kind of thing. 80% is ischemic, 15-20% is hemorrhagic. Hypertensive, again, major part of it is just hypertensive hemorrhagic stroke. Then you come to the aneurysms and AVMs and other malformations. So as we go away from here, so this is an important thing that you all should know. Be fast are the symptoms that we tell the patients also. Say somebody had a small stroke, we tell the family and the patient that if you have these symptoms again, which have to be sudden in onset. Sudden onset, unilateral limb weakness. So it could be upper limb, lower limb, or both upper limb, lower limb, but on one side. Usually doesn't happen on both sides together. Slurring of speech, that could be one of the signs. It could be total aphasia, it could be dysarthria, or just slurring. Dizziness, vomiting, imbalance can be there, especially if there's large cortical area involved, or the brainstem, or the posterior circulation is involved, then cerebellum is involved. That can lead to a lot of dizziness, vomiting, imbalance. And if it's a major large stroke, it can start affecting consciousness itself. So these are the things that you must remember. So be fast includes balance, eyes, face, arms, speech, and time part is that you have to just reach quickly, because the longer you take in acting on stroke, the worse it is. So it's just like, a heart attack, you have to run, rush. Same is with stroke. People often have this weakness and they sleep. They go to sleep. And I've seen people say रात को थोड़ी सी weakness हुआ, लगा कि सुबह तक ठीक हो जाएंगे, सो गए. And by morning, the entire area is gone. The stroke progressed. Maybe it was a small one in the beginning. By the time patient woke up, already things were out of control. So the basic pathophysiology is that cerebral blood flow is around 50 to 60 ml per 100 gram per minute. It reduces if the blood flow is low. Is it because of a blockage in the blood vessels? And the infarcted area, the area undergoes infarct when it has kind of gone below 10 ml. So now what area required 50 to 60 ml per 100 gram has come down to, is now receiving less than 10 ml. So when it's receiving less than 10 ml, that area is more likely is gone now. And anything in between, kind of 20, 30, up to 30. So 30, we usually just keep benign oligemia. Even up to 30, things remain fine. Function is not lost, but it's definitely less. So you have a lesser flow. But 10 to 30 is where you will have loss of function, but that deficit will not become permanent. The area is not dead yet. It is that part which is most important for you in stroke. This is the penumbra that we want to save. Of course, we want to know how much is the infarct. We want to prognosticate the patient. We want to understand the deficit. But when you come and think about the intervention part, whether you want to intervene or not, you see this kind of stroke. MC has occluded, large vessel occlusion, MC territory is gone. Should you intervene? It's a large vessel occlusion. Why not intervene? That territory is gone. There is nothing to save. Even if you open the vessel, you are only introducing complications of the procedure and not real benefit because the area is already dead and rest of the brain is still receiving supply from somewhere else. So only the part which has severe oligemia, 10 to 30 ml, blood is being received, flow has been received and has lost its function because of that. So you may have little less flow, you may have 40 ml flow, but speech is totally fine. So the speech area has 40 ml flow. Does it really matter? That doesn't matter. It's just benign oligemia, blood thinners and everything is sufficient. But in that area, blood flow is less than 30, 25, and now you're not able to speak, but it is not less than 10. So that means you can still save that area if the blood supply can be restarted. This is the basic premise of stroke intervention. So if you remember this, you will always be clear in your mind when are you going to intervene and when you are going to now let the patient be on medical management that we can't really do anything. So from there, if the infarct is already there, he might develop edema, he will require perhaps a decompression also. But really, you can't do anything and you'd only end up causing more damage. So just understand when and where you should do something. When you say things to your colleagues, it should be very clear to them also that this person understands what he's doing. He's just not a technician who's doing this procedure. He understands what is the thought process. So when I was in my fellowship at Kowai Medical Center, we were the first on call. The neuro IR was the first on call for any acute stroke within the 6 to 10 hour window period. So we used to go and assess, get the MR done, and there was a WhatsApp group where everything would come up. So we'll put everything, we'll put the history, we'll put the imagings, and then the neurologist and the senior neuro IRs, they could just say, okay, we need something, we don't need something, this can be done, just lyse it. This patient doesn't reach thrombectomy, no large vessel, just small vessel, but stroke is there within first 4.5 hours, lysis has to be done. So these are the kind of decision making that used to happen, and every day we used to have 4 or 5 such calls. So over 2 years, if you look at those many number of calls, 365 days, 700, I mean 2500 plus stroke calls, you realize it becomes a reflex as to what needs to be done. But said that, given and I've said that it's still this science is evolving very fast. We are getting new. Uh, Ideas, new evidence every day that maybe even this can be treated. So what was considered first कि अगर diffusion changes आ गए हैं totally, let's not do anything. But again, more and more data is coming. You open that vessel, reversibility in diffusion changes is being shown. So maybe 6 months, 1 year, 2 year down the line, people might start saying open every vessel. We have shown that it benefits in the long run, not opening versus opening. Whatever the brain imaging, if you see large vessel occlusion in first 6 hours, just open it. It may end up reaching to that stage, just like it is in cardiac status. You just have to, they're going for everything. PCI, open karna hai. Because that will streamline things, make it easier. You don't have to think so much कि करना है कि नहीं करना है. आपको large vessel दिखा, अगर things you get enough evidence to do that, you will be able to go ahead. But for the time being now, we will stick to this penumbra region. And this is what is the basic idea, that there is a ball, so there is a torch, distance is there. This is the area which is a pure shadow, whereas this area is receiving some light but less. And this is the area we want to save. So the edema that happens in the brain can be of two types. One is the vasogenic edema, that is because of oozing of capillaries. This is there on T2 images, FLAIR images. That is kind of the late